welcome. Yeah, welcome to this public briefing of the Standing Committee on Social Development. My name is Jane Wayalin Armstrong, and I am the MLA for Montpellier Cloutier Region, Chair of the Standing Committee on Social Development. I will now ask members in the rooms to introduce themselves for the record, followed by those online, and we'll start to my left.
Good afternoon, Karen Tester, member for Range Lake.
Good afternoon, welcome. Danny McNeely's the MLA for the Satu.
Julian Morse, MLA for Frame Lake.
Good afternoon, Cheryl Yakalaya, member for the Decho.
Good afternoon, my name is Kate Reed. I'm the MLA for Great Slave. And I am Shauna Morgan, MLA for Yellowknife North.
And those online? Okay, no members online, so thank you, members. Today we will receive a briefing on primary health care reform from the Minister of Health and Social Services. Please note this meeting is being live streamed to the Assembly's social media channels. I would like to remind all members and witnesses to direct all questions and comments to myself as chair and to wait to be recognized before speaking to help us have a smooth meeting. So now I will now pass it on to Minister Lesa Semmler. Please proceed with your presentation.
Thank you, Madam Chair, and good afternoon, Madam Chair and members of the Standing Committee. I thank you for inviting me here today to discuss the 20th Assembly mandate item on primary health care reform. Today's briefing will highlight the approach to redesigning primary health care in all regions of the Northwest Territories. This work was established 10 years ago through Standing Committee direction to improve Indigenous health outcomes and explore how to make a system that is more responsive to Indigenous clients and incorporates traditional healing into primary care. The Community Culture and Innovation Division, in collaboration with Indigenous communities and governments across the Northwest Territories, develops and delivers equitable health and wellness initiatives. Through relationship building and trust, the team works to identify and address the root causes of health inequities, dismantle systemic barriers, and improve both experiences and outcomes for Indigenous peoples. This is the division that is leading the primary health care reform work. Health systems across the country are currently experiencing crisis, and to address these complex issues, it is important to undertake long-term planning and design together with Indigenous communities. Today's presentation will list the steps we are taking to establish an overarching framework to guide primary care transformation over the long term. With me today, I have Joanne Chiquero, Deputy Minister of Health and Social Services. Online, I have Perry Heath, Assistant Deputy Minister, Corporate Service and Cultural Safety. Sarah Chorokowski, Assistant Deputy Minister, Programs. And with me to my right, I have Nina Larson, Director of Community Culture and Innovation. And from the Northwest Territories Health and Social Services Authority, I have Dr. Claudia Kraft, the Territorial Medical Director. I have online Joanne Ingram, Executive Director, Clinical Integration. Jennifer Thoreau, Chief Operating Officer, Yellowknife Region, here with us in the room. And online, Dan Florazone, Public Administrator of the Territorial Board of Management. Thank you, Madam Chair.
Okay,
people
thank you.
online cannot hear, just so you're aware.
Okay. Okay, now who's going to do the presentation? Nina. Nina? Okay, go ahead, please.
Okay, thank you. Primary health care is the foundation of our system, and right now it is not working for everyone. Only 59% of NWT residents aged 18 and older have reported having access to regular health providers in 2023, compared to an average of 84% in Canada. Indigenous residents face even worse gaps. Despite the highest per capita health spending in Canada, we're seeing some of the worst health outcomes and access. This is a serious equity issue, and it is why reform is needed. When people do not have access to high-quality primary care, everything else falls apart. We know the traditional model of care is no longer working or possible. Globally, systems are moving to team-based care to improve access, quality, and staff morale. In the NWT, our integrated care team is inspired by the Alaskan NUCA system. It's based on relationship, a most responsible provider, interprofessional collaboration, and shared principle of providing person-centered, continuous, and comprehensive care. But care teams alone won't fix things. Transformation in the NWT means rethinking how the system is built and addressing the barriers: racism, mistrust, geography, and unmet needs. In government, as you know, we face different kinds of problems. Some are simple, others are complicated, and some, like primary healthcare reform, are complex. Complex issues involve many interconnected factors, unclear cause and effect, and multiple stakeholders with different priorities and opinions. Historically, we have designed parts of the system based on assumption, such as the belief that everyone across the NWT has the resources, supports, and tools needed to access primary care. While integrated care teams are a critical step forward, creating teams alone won't solve the deeper problems. Nurse-led models in small communities and physician-led models in larger centers provide essential care, but they are often stretched beyond what is sustainable. Our approach must be community-driven, designed with Indigenous communities, and centered on those most affected by the change. This is essential because collaboration through integrated care team helps, but systemic barriers, especially racism, still limits access and outcomes. Reform must be built on what works while fundamentally changing what doesn't. Cultural safety and anti-racism are not optional and must be central to how we reimagine access and quality of care for service delivery. The definition of cultural safety is an outcome where Indigenous peoples feel safe, respected, free of racism and discrimination when accessing health and social services. Anti-racism is the ongoing action to identify, address, and prevent racism in all its forms. That's why primary healthcare reform is not just a technical problem. It's one of the most challenging and necessary transformation we must undertake. The iceberg analogy is something we often use to describe how racism manifests at different levels across the health and social services system. It helps us visualize what is visible and what lies beneath the surface, the deeper systemic roots of racial inequity. What we see above the water at the top of the iceberg is one expression of racism, which is at the interpersonal level. These are the most recognizable. Indigenous residents across the NWT, including in urban centers like Yellowknife, consistently report receiving delayed care, being ignored, receiving lower quality care, and having their symptoms dismissed. This form of racism is harmful, but it is also one part of a much larger problem that needs to be addressed. As we move just below the surface, it's institutional and structural racism that we talk about. Racism becomes more systemic, built on how our institution operates. Institutional racism shows up in policies, practices, and procedures that may appear neutral, but systemically disadvantage Indigenous people. This part of the iceberg reflects how the system continues to over-resource, over-serve, and validate white dominant culture, which looks like acceptance or normalization of substandard care, dominance of biomedical model, and absence of Indigenous healing as prevention or care options, policies and programs not informed by community, and limited resource allocation. This is happening all while the system is under-resourced, underserves, exploits, and oppresses Indigenous peoples and people of color. Finally, at the base of the iceberg, the part we rarely talk about, are the deeply embedded belief systems that uphold racism. These include colonialism, white supremacy, and racial hierarchy that shape how we define health, who we listen to, and whose lives are considered valuable. These ideologies are passed on through institution, education system, leadership norms, and organizational cultures, often without being named. These ideologies reinforce inequities for Indigenous people and people of color while privileging the dominant white population. So what do we do? To address racism as a social determinant of health, we must act at all levels of the iceberg. At the surface, we need to address interpersonal racism by holding people accountable and creating safe environments. Below the surface, we need to dismantle policies and structures that reproduce inequity and build in accountability for equitable design and funding. And at the base, we need to look at transforming organizational culture. Racism is not just about individual attitudes, it's embedded in how we do our work. It is part of the system, and system can be redesigned. That's what this work is about. Our definition of equitable access doesn't mean treating everyone the same. It's about removing the barriers that prevent people from reaching their full self-determined health and wellness potential while recognizing that we all start from different places. Our goal is simple and clear. All residents have equitable access to cultural safety, team-based care with integrated care pathways connecting seamlessly to the full range of health and social services. We will get there in 3 ways: by strengthening internal capacity for cultural safety, anti-racism, and equity, and centering Indigenous people's voices, needs, priorities in care models and pathways, and supporting community-based regional team co-design solutions tailored to local needs. The good news is that we're not starting from scratch and we have strong assets. We already have salaried physicians, which is a major asset because they support team-based, equitable, and relationship-focused care. Unlike fee-for-service models used in most of Canada, where physicians are paid per visit and often operate like small business owners, salaried physicians in the NWT are employees of the GNWT. This allows them to spend more time with patients without financial pressures to increase volume, collaborate more effectively with other team members, work in remote communities without needing to manage overhead or billing systems, and focus on continuity of care, relationship building in complex cases. We also have a shared electronic record, although now outdated, and we have also built strong relationships with Indigenous communities through a single governance model. Integrated care teams are showing promises, and staff across the system care deeply about getting this right. While challenges remain, especially around staffing and resource flexibility, the foundation demonstrates that culturally safe, people-centered, and community-driven care is achievable and is already making a difference. To make transformation real, we will need to align and make progress on 7 enablers that were designed by system leaders based on evidence, such as a learning health system rooted in just culture, strong Indigenous partnerships, modern digital infrastructure, flexible funding, and a representative workforce. These enablers will help us move from good intentions to impacts. Primary healthcare reform is guided by clear principles: clarity and transparency, integration of traditional healing, reconciliation, integrated people-centered care, access and quality of care. We will achieve change by embedding cultural safety, aligning services with community needs and local data, and looking at optimizing team roles, strengthening Indigenous workforce participation, and including mental health and chronic disease supports. We have developed a robust approach to developing a strategic framework and performance measures that is based on diverse forms of evidence, including survey response, engagement, Indigenous Systems Change and Literature Reviews. It seeks to center Indigenous knowledge, values, and priorities through a community-driven process. The team leading this work includes a majority of Indigenous staff who have been working to facilitate system transformation through co-design and collaboration across the health and social services system. The process will involve 4 phases from April to December 2025, and these 4 phases include key milestones. First, a summary of over 75 existing engagement reports and 27 newly developed community wellness plans to understand what we have already heard from Indigenous communities about what is needed for primary health care. Second would be research to focus on relevant questions for the design of Indigenous-centered team-based care models and equitable access. Third is engagement with Indigenous communities, government, and community organizations to share initial finding and seek feedback. Then we will host roundtables to develop practical and forward-looking strategies to advance each primary healthcare reform enablers. We will have dedicated sessions to hear from professional associations, including the NWT Medical Association and College and Association of Nurses and NWT and Nunavut. And finally, we'll have site visits and client journey maps to understand how people are currently accessing and experiencing and receiving primary and small community care. This work will be overseen by a committee composed of people with expertise, including academic, lived experience, land-based, and cultural knowledge in primary and community care, health system transformation, community wellness, and equity and cultural safety. We have developed a Made in the North curriculum that will walk regional teams through the steps needed to engage in a primary healthcare reform change initiative. It's a practical, community-driven tool to support regions and communities in designing, implementing, and sustaining change. It's not just about what we do, but how we do it. Regional endorsement will serve as a milestone by showing that communities are ready, have completed the first steps, and are committed to moving forward with primary healthcare reform. Ultimately, primary healthcare reform will be the guiding strategic framework for system-wide change across the Northwest Territories. It will align initiatives, build accountability, and help us work differently by working together towards equity, reconciliation, cultural safety, and better health outcomes. Merci.
Okay, thank you. Thank you for the presentation. I will now ask the member if they have any questions. Okay, MLA to start.
Thank you, Madam Chair, and thank you very much to the Minister and her staff for the presentation. Look, cultural safety and equity and this work is very important. I've heard far too many very serious stories about, and I'm sure we'll hear that today, but about the magic Tylenol, the one pill that will cure all your ailments, and that's sometimes the only treatment people in Indigenous people in small communities get, and that's resulted in actual loss of life. So this is very important work. But I want to question some of the assumptions on the other part of the primary care system. On page 12, we have a list of a strong foundation that's going for us. The first point, salaried physician compensation model. Well, we do have that model, and yet we have lost 9 family physicians, Madam Chair. The Medical Association tells us 60% of physicians in the Northwest Territories want to leave. Our electronic medical record system, there's interjurisdictional issues with there where we can't transfer records to hospitals in Alberta, which only frustrates care, causes duplication of scans, and sometimes transmission of paper records. The governance structure, the minister just dismissed that government structure because it wasn't working. And we have an MNP report that has finds major deficiencies with the leadership structure. So I have to call into question this foundation. I think on paper it might be a good bullet list to build to try to present a strong foundation, but foundation is crumbling. And we hear that from patients, we hear it from the frontline workers. We just had a presentation last week from the Medical Association on this. I hear from nurses every day. This is not okay. And although this work is very important, if that foundation crumbles, primary care reform towards these ends isn't going to matter as much as ensuring we have healthcare staff that can provide the care in communities, in Yellowknife even, because that's how dire it's getting. So I'd like to ask, what are we actually doing to address the foundational piece for primary care? And I'll start with a very simple one. How are we going to keep the ER open? Thank you.
Minister?
Thank you, Madam Chair. I'll keep my comments short, and then I'll pass it to the public administrator to answer that question. I think when we look at our governance structure and when we look at the escalating chronic disease over the last many, many years, the population outside of our regional centers, that is where we're seeing that there needs to be emphasis, because that is what we have heard from our governance structure, which is the regional wellness councils. They have raised these issues for 10 years, and we have not had a way to move those priorities forward within, and as being the minister this last year, we worked with them, we heard from them, and we put a public administrator in place to look at our governance structure, but to hear those voices now, and that is kind of where we're at. We're hearing the voices of those regional chairs. We've heard them. I've heard them. I know what the priorities are. As an Indigenous person, I know what those priorities are, but how do we move those things into our system? And primary care reform is going to do that. And I can turn it over to the public administrator if that's okay with you, Madam Chair.
Yes, Mr.
Dan Florazone.
Florazone. Yes, please, go ahead.
Thank you. Thank you, Madam Chair. And thank you, Minister and MLA, for the question and the statement. I think it's fair to say we've got some challenges, and the nation as a whole is facing quite a few challenges. I've had an opportunity to work in the health sector for 40 years. And I'm not trying to prove to you that I, am old. I think that's pretty obvious just from my picture. But with the experience that I've had in looking at high-performing organizations right across the globe, and the deep experience I've gained in Saskatchewan and Western Canada, the experience I've gained in Nunavut, I can tell you, you've got a lot to be proud of in the Northwest Territories. And the credit goes to governors, including MLAs, the minister, the government, past governments, the current administration, and physician leaders, just to name a few. You mentioned a couple of the challenges, and these are not small challenges. The EMR, the real benefit is you're on one system. And while it's not interoperable with Alberta, we're on one system. We at least have the consistency to be able to communicate between our rural remote areas and Stanton. We do need to refresh, and that is an investment that's required, and we seek your support to do that. That refresh is being called upon by the physicians to move forward. Now, the physicians have been really clear. I've met with them several times. I got to tell you, I'm really impressed with the leadership, and I think you are as well. The leadership from physicians and from staff in general has been very positive. These issues are being presented to you as problems, but not insurmountable. So the three areas that the physicians have spoken to, and I'll just kind of summarize them very briefly, and they've done a good job of conveying them to this committee. The first is interest-based bargaining. So the physicians you met with are the bargaining agents on behalf of all physicians in the NWT. They are interested in putting their interests forward so that their voice can be heard, so that they can understand and we can understand the various interests in moving the agenda forward. They're interested in hearing from the minister, from the government, on what the future plans are in the NWT. Where is it that we're headed? And I'll touch on that in just a moment. They also talk, number two, about incentives, about payments, about keeping up with the competitive framework that currently exists in Canada. And actually, it's a global framework. We're competing globally for precious physician resources. In fact, we're competing globally for precious clinical resources, non-physicians included. And the more specialized they are, like the ORs or the ED or ICU, the more difficult and challenging they are to recruit. We are absolutely on the same page. We need to be competitive. We need to have incentives that are modernized and up to date and really speak to the need to recruit and retain the best. And that brings me to the key point here is recruitment is one thing, and a lot of our activities are locums and short term, and we need to do our best job there. But we also have to keep our eye on the horizon, the need to actually retain clinicians, retain staff. And the only way to do that is to create an attractive enough environment, give them the tools, the pay for sure, but the working conditions that make and appeal to a vibrant workforce. The third is enabling technologies. And these are the types of technologies that physicians and others have been quite clear with us on. They want the latest in artificial intelligence. They want the latest in virtual care, point of care testing, the kinds of tools that allow them to work remotely, allow them to provide service and coverage for each other. Now, I want to take you to the broader picture, and that is that Stanton is a very busy place. And most days, many days, it's feeling overwhelming to deal with the influx of patients, the volumes. When you look at that problem, the knee-jerk reaction is just simply more resources. But I got to tell you that more resources is a good short-term strategy. What we need to do is uncover the why. What's the root of the problem? And while there's some aging of the population, there has been huge, large-scale growth in the population of Yellowknife or even of the Northwest Territories. That aging has certainly had an influence on chronic disease, on our need for primary care, and our need for modernization of our health system. But if you were to look outside of Yellowknife, and I'm really pleased you mentioned this, I know that you're closer to this than I have been. I've been in Nunavut and I've been in northern regions. But specific to NWT, our services in the rural or lack thereof, our supports at home or as close to home as possible that have gaps in them, have maybe not taken advantage of the latest in technology, the latest in flow and improvement, have meant that care needs that are crisis needs end up traveling down the road through from health cabins to health centers and to hospital and trip south sometimes. And so when we take a look at that patient journey, it's crystal clear that there are improvements needed throughout that entire journey. In fact, the best thing in terms of patient-centered care is to not be a patient in the first place. If we can avoid the crisis that created the conditions where people need to travel to Stanton, where they need to visit the emergency department, that's key. Now, none of this really matters if we haven't solved our short-term problem. The ED in Stanton is not going to close. We will be very clear with the public and transparent with the public if there are program or service disruptions. We triage, we staff. We've got a range of other staff that will be capable of supporting and assisting. We today will be releasing later today with the government a framework and a payment a system for locums, and we'll be communicating that through to our network. What is going on? What are the improved wages and pay scales and programming in the Northwest Territories? This negative narrative has got to be flipped. We've got to create an attraction for practitioners to come here. And I'm not being Pollyannish about this. I got to tell you, I'm sitting here this morning and this afternoon in Saskatoon. I've reached out through my network to ED docs who have indicated an interest in coming to Stanton. What they've told me is that they're too busy. And right now in Saskatoon, a population that's about 10 times larger than the Northwest Territories, has 3 hospitals, they're running a vacancy of 20% in their EDs. They, like us in Yellowknife, like every other jurisdiction across Canada, are facing some very significant challenges. We are going to work hard. I'm confident in hearing from the leadership team that they're working hard. So here's what we're going to focus on. We're going to improve access. We're going to focus on the journey of the patient. We're going to assess primary care from the perspective of the patient. We're going to support team and teamwork and engagement. And I'm going to call upon the physicians and the healthcare providers and the unions and the regional wellness councils to work with us, not only in mapping a journey, but co-designing a future state. We're not going to seek perfection. We're going to seek improvement. And we're going to keep at it persistently year after year after year. Madam Chair, just one last comment, and that is on governance. I may be a PA, a public administrator, but I'm here for a short time. I've been asked by the minister to achieve certain things, but very much work with our existing governance structures, our regional wellness councils, engage with staff, engage with community, engage with physicians. Those instructions have been very clear to me. I got to tell you, what you have right now with the regional wellness councils throughout NWT is probably the best of the best practice I've ever seen in governance. Now, if everything has worked, it would mean we're not only high quality, high performing, but we've got a balanced budget, and we all know we don't have a balanced budget. There's work yet to be done. So in addition to my accessibility and access work, I'm going to be contributing to the idea of sustainability. The minister has charged me with improving care and reducing costs, both at the same time. How do you do that? That's the magic. You do it through engagement. You do it through idea generation. You do it through innovation. You do it through technology. You do it by looking at areas like medical travel and seeing if we could avoid the travel in the first place. Thank you, Madam Chair.
Okay. Thank you. Thank you. MLA Tester, do you have a follow-up question?
I was taking comprehensive notes. That was a very thorough answer. Well, Madam Chair, I've seen Mr. Florazone's mandate letter, and I fear he's in for a much longer stay if he wants to get it all done than a short-term stay. You know, I think we could be this could consume what we're talking about today if we continue on this path. But it's sufficient to say, like, those are all the right things to say, but the front line doesn't feel that way. And until I hear from the front line and from patients that things are improving, things haven't improved. So we need concrete actions. We need more than very, I'm not questioning anyone's experience or drive or commitment to improving healthcare. We're just not seeing actions yet. We have a lot of talk. We don't have anything concrete. So to that end, this project, we've seen the timeline for this year. 2026 will have a strategy. Are we going to have a timeline for the actions that occur from the strategies that can be shared with today? So we know whether this is going to be a 2027, we're going to start to see movement, or is it 28, 29? Like, what's the time frame for actual getting these reforms in place? And will there be costing for these actions as well? Because it's very difficult to find meaningful actions often, especially when you're talking about system transformation and embedding anti-racism into what we do, which is a whole, you have to relearn how to provide primary care because that's how integrated biases are into the system. So what's the costing for these actions going to be? Because if this is going to be a worthwhile undertaking, there needs to be a dollar value attached. Thank you, Madam Chair.
Okay. Minister?
Pass it to Nina.
Thank you, Madam Chair, and thank you, Emily Tester. So while we develop the strategy, we are still going to be continuing the work. We're not going to pause primary healthcare reform while a strategy is under development for publication by 2026. Work currently underway for easier solution than broad transformation include looking at maximizing scope of practice for community health nurses, practitioners, licensed practitioners in allied health. Scaling innovation that took place in communities for the past couple of years through primary healthcare reform, such as virtual care in Fort Good Hope. Determining ways to look at how we can ensure continuity of care in small community health centers when nurses are not available, and on mandatory rest periods. When we have quick solutions that come to light when we work with each region, those solutions are immediately implemented by staff. When we see that the issue is a territory-wide issue, that's when that problem is brought to the territorial level so we can find systemic solution, and it takes a bit longer. In terms of timelines and costing, I had mentioned a cohort of all CEOs who will undertake data analysis, so understand what is the needs of their population and what would an integrated care team composition look like in their regions, and then they'll populate a proposal or endorsement form that will be shared with government and for the sustainability team to also take into account as part of their data analysis. Thank you.
Okay, thank you. Now I'll go to Mr. Morse, MLA Morse.
Okay, thank you. Yeah, I mean, generally, I think that we have some great high-level goals here, and I'm pleased to see the system setting primary care reform as a top priority. I think it's been established quite well across Canada that this needs to be a goal for the healthcare system of Canada generally. That kind of a refocusing on primary care and building out of kind of the way the healthcare system is structured around a foundation of primary care is the key to ensuring that all Canadians receive adequate health care, and particularly in the north. And I think, you know, it definitely gives me pause to see that statistic that we're so far below the Canadian average for primary care access. It tells me that we're really getting at the right problem. I think that, you know, the previous speaker kind of highlighted that, you know, besides all that, besides the high-level goal setting, we've got, you know, some significant challenges in the system. And I've mentioned this on the floor to the minister a few times and in discussion. And, you know, I just something that stood out to me, and I don't really want to dwell on it or ask questions about it in particular, is just that when I saw the presentation and saw the slides, you know, we're talking about a strong foundation, we're talking about like all of the positives, and it is good to do that. I would just note though that it's no secret to anybody that the system is struggling with some significant challenges. And I think it is really important to not only focus on what's good, but also be very clear with ourselves and with the public that we know what the challenges are and that we are working to address them directly. So I think it's really important to be open about acknowledging them. I think if you tell everyone's okay in a system that everything is very clearly not, people run the risk of feeling misled and feeling disillusionment and lose trust in the system. So I think it is important to just address the issues head on, because I mean, for what it's worth, they're not a secret to anybody. I mean, they've been raised in briefings in this room, they've been raised on the floor, and of course they're raised by the public constantly, you know, in the media, and so we know what the problems are. Let's get clear about it, addressing them. So that's just a thought. I want to get into some specifics. The first one is just one that Mr. Florzone mentioned, and I think it's important to highlight, and that is the lack of interoperability with Alberta in our record system. You know, I was just dealing with this issue with a constituent today. I think a critical change that's needed is to establish interoperability, because our system is so dependent on medical travel to this neighboring jurisdiction. And, you know, I've talked to a lot of residents who face unnecessary stress, barriers, and paperwork as a result. And it's also important to note that I'm sure you're all well aware of that it also burdens our healthcare practitioners with paperwork, right? And adds to the administrative burden that people are dealing with. So my first question is, can we, and quickly, get a solution to this? If there's legislative change needed, I don't think there's anybody in this room that would be against fast-tracking it. To get a solution to this problem so that when patients are traveling between jurisdictions, the last thing they're thinking about is paperwork. They can just focus on their health, and so can the practitioners on either end of receiving the patients. Thanks.
Minister?
Thank you, Madam Chair, and thank you for the question. And what you're asking is the exact question that I had initially asked the department right from the start, because over the years of being an MLA and over the years of being an NIHB navigator and over the years of being a healthcare provider, that is constantly a battle between records between NWT and our referral site in Alberta. And so one of the questions I was why can't we just have a same system so that they could read each other? And I'll turn it over to the Deputy Minister to answer that. Thank you, Madam Chair, and where we're at this point and the options that we are trying to look at. Thank you, Madam Chair.
Okay. Thank you. Joanne?
Thank you, Minister, and thank you, Madam Chair. First of all, I want to acknowledge that everything you just said, we don't disagree with. So first, if I can go back to your first comment about the need, I think really it's about the need to balance. The reality of our system is that we have some complex problems that require complex solutions, and we have some good foundational work that is happening also in our system that, as the public administrator had noted, that we are in some ways advanced compared to some other jurisdictions. And the things that you have raised around medical travel, electronic health records, the movements of our patients, the administrative burden, while we're here talking about really the principles behind primary healthcare reform and how we're going to do that, those are all the other things that continue to, and many, many other things that continue to happen behind the scenes. So we agree that we need more. The PA talked just previously about the need to be able to provide better virtual care, more opportunities for patients to be in their homes or in their home communities and not have to travel, whether that is between Yellowknife and our own communities, but also in Alberta. We are investing in this current year to renew our electronic health record. And so our priority would be to have a system that is seamless with Alberta. But that's not up to us only. So what I can share with you is that those conversations are alive and well with Alberta around what would that take for us to have a system that either we piggyback onto theirs, their existing system, or that whatever system we implement, they are easily able to read our client information. So much of that paperwork that currently flows between the Northwest Territories and Alberta has to do with both the Northwest Territories and Alberta's medical record system or health record system, as well as both legislation. So what I can say is that our goal is to have a system that literally speaks to one another. We're talking the same language. We're trying to fast track that with Alberta and to get that happening in a timely way. But I do want to press that we are one of the only jurisdictions in this country that has one record for each patient that everybody who practices in our system can read and access. So in 33 communities, we have an EMR that is accessible to all practitioners for every patient. And so we've come a long way, and yes, that system is outdated, as Nina had mentioned earlier. And so that's part of the work too. It's not just about how can we talk to Alberta, but how can we have a system that actually better supports our clients in our own territory, and how we can actually relay that information back and forth between the jurisdictions. And I say primarily Alberta because that is the jurisdiction of our closest referral. So I hope that was helpful.
Okay. Thank you. Mr. MLA Morris, do you have a follow-up question?
I do, thanks. Yeah, I appreciate that answer. The only follow-up I'd have on that answer is just I'd like to see a timeline for when they're expecting that this change could be brought about. My next question is about the concept of the primary care teams themselves. I am supportive of the concept. I think what's been highlighted for us MLAs at the outset here is just that in our eagerness to establish the primary care teams, we might not have thought about, or maybe we did think about, but just don't have the capacity for ensuring that the appropriate number of patients is assigned to a primary care team so that they can actually have adequate access to care. So my understanding from my small amount of research on this is that it's between 12 and 1,500 patients per primary care team is appropriate. And here in Yellowknife, I don't know what it is across the territory, but I know here in Yellowknife we're sitting at about 5,000 patients per primary care team. So it seems that we need a number more teams in order to hit that adequate kind of patients, number of patients. I forget what the term is for the group of patients, but so I'm curious, are we setting goals for these kinds of parameters, developing plans for how to achieve them, and timelines for when those things can be achieved? Like, are we thinking about that? That's, I want to use the word term span of control, but I'm not sure if that's the term that medical practitioners use for their group of patients. But yeah, I'm just curious to hear about that. Like, are we thinking about ensuring that the primary care team is scaled in such a way that it can provide adequate access to care for all the patients under the team? Thanks.
Minister?
Thank you, Madam Chair. I'll have the Deputy Minister start, and then I think I'll have Dr. Kraft kind of talk about the decision from 10 to 4, so that, yeah, okay.
Deputy Minister?
Thank you, and thank you for the question. What I would just say first, mostly what we see across the country in relation to panel sizes is often related to physician practice. And in a country that is primarily fee-for-service, it's a little bit, when you talk about primary health care reform, you're almost comparing apples to oranges. But what I would say to you is it's very important that we have that, whatever, if it is a number that we land on, or that whether it's the team number versus the clients that are served is really important. And where primary health care reform comes into this is it's not just about one patient having one provider. So it's not about, so say for example, if a physician is rostered 1,500 patients, now if you were working in Delaney, that would be very different because there isn't a resident physician there, as an example. So for Yellowknife, I would say, where does the nurse practitioner come into that formula? Where does the LPN come into that formula? Where does the counselor come into that formula? So what primary health care reform is looking at when we talk about a team approach is also about what does that look like from a panel size perspective. And so I know that this work is, I worked at the Health Authority 10 years ago, and that work was ongoing because it changes over time. We get new information, et cetera. But I will hand it over to Dr. Kraft to talk about what the work is that's currently underway in this arena.
Dr. Kraft?
Thank you, Madam Chair. Thank you, Minister, and thank you, Joanne. So thanks for the question also. Absolutely, the answer is yes. We're thinking very deeply about workload because we're really trying to make sure that we understand how do we meet the needs of the patients that are in each of these, we refer to them as panels or team groups. And so, and what is the right complement of providers that need to be brought into that team in order to really meet those needs. And that complement of providers is going to be a little bit different in a place like Yellowknife, where you can recruit or retain certain providers. It's going to look different in a small community where we may be relying more on virtual practitioners, but on-site health workers. And it's, of course, going to matter, it's going to look different if it's a community that's identified needs that relate more to mental health, for example, than to chronic disease like diabetes. So each team, each community, and each group of providers, frontline workers, has to be really engaged in helping us figure out what that balance is. So there are formulas, those are really helpful for trying to assign gross funding, but they don't really speak to the final product, right? What does it actually take today? And maybe that's going to be a little bit different in 6 months or a year as the needs have changed, or if we've filled gaps, or if we've addressed some of the chronic disease problems. In Yellowknife, for example, you mentioned there's about 4,000 patients per panel. But keeping in mind that, what we're aiming to staff in each of those is, at least one nurse practitioner, a community health nurse, program assistants, LPNs, access to a behavioral health worker, and 3 physicians for every day. And 3 physicians on a given day is much more than 3 FTE. So, when you look at it like that, 4,000 people on a given panel, or 5,000, might be actually, quite reasonable if we're looking just apples to apples, oranges to oranges around the country. I think you referenced about 1,300 per team. That's one number. It's often related to like a family physician, what one individual's component might be, in some cases with a team. So what we've been doing in Yellowknife, so today's process, which is different than what it looked like 6 months ago, and it'll be different again in a year, really involves having the regional committee. So this involves all the practitioner voices. So we have physician representative, we have a nurse practitioner representative, a community health nurse representative, program assistants, LPNs, holistic wellness advisors, administrators, and they're all together unpacking these problems of how do we deliver the care? What are the tasks that are needed? Who's the best person to do it when we talk about providers working to full scope, right? We have this complement of staff, assuming we can get them, and vacancy is absolutely a real concern. What's the best way to organize that care? And part of the cultural safety change is that we don't prioritize only one voice, right? We are intentional about saying, what are the power structures here? How do we make sure that each of these voices, each of these people that are close to the patients, and patients themselves now, how do we have them in the room for that planning and have equal authority in voicing their perspectives? And so that's a big change for Yellowknife, certainly, in terms of how do we distribute that decision-making and distribute the access to that sort of collective power. It's not comfortable, right? But I don't think primary healthcare reform, when we see the principles that we're trying to apply, I don't think it's meant to be comfortable. I think it's meant to address the fact that for many of our clients, many of the residents, accessing healthcare has not been comfortable. And the system has been designed around people like me, right? Powerful white doctors. And to get the system to be designed for patients, and Indigenous patients in particular, we do have to do things a little bit differently, and it's not easy, but I'm so grateful that we have staff that are super engaged in this, right? Like, we have amazing healthcare providers who I really believe are willing to do this journey and to live that discomfort because they believe in the outcome, right? Which is equitable healthcare and a health system that they believe in. Like, I think that is, when we think about what are our strengths, absolutely our staff are on that list. And the people, when we talk about the ones we really want, right? People who will stay here. If we didn't train them here, if they're not ours to begin with, right, northern workers, because we absolutely want stable representative workforce, and that's people who are from the north. But if we think about the people that really stay, right, and I know this of the staff, my colleagues that I work with, and I know this of the recurrent long-term locums, the ones who really engage with us over time, they're very values-driven. Right? They want to be a part of delivering great care. They want to do those jobs without too much bureaucracy and too much red tape, but they want to know that at the end of the day, they've served people's needs. And primary healthcare reform and a good primary healthcare system is going to keep people like that. And I think it's also the reality for new recruits. We know that across the country, fewer and fewer people are choosing family medicine, right? Primary healthcare. Those that are, and I think those that will choose to do it here, are going to be the ones that think that it's important to be a part of reconciliation, it's important to deliver equitable care, and team-based care we know is an attractant to fresh grads, to young professionals. Going it alone, the days that, you know, I was on the edge of it, of like hang up a shingle and you kind of just do your own thing, that does not speak to the doctors of the future. I don't think it speaks to the nurses or the nurse practitioners or the community health nurses or the behavioral health workers. Like, we have to invest in this and be all in if we want to have the right providers, right? Not the mercenaries, not the ones that are just there for that 20 patients a day fee for service, but the people that are really going to be in it.
Okay, thank you, Dr. Crabb. I have MLA Morgan.
Thank you, Madam Chair, and thanks for the opportunity to have this conversation today. I do strongly believe we are all on the same page in terms of these important priorities, principles. That's great. That's a great place to start. And I certainly, I agree with everything that's been said in terms of what we're striving to achieve. Great. I think where is the conflict and frustration is around the implementation, the hows, and the relationships necessary and involved in that implementation, right? One question that certainly popped to mind reading and hearing the presentation is that it seems that you're telling us that the process of primary care reform is just beginning now, and you're in the phase of gathering evidence, and starting in June, there will be sort of engagement, which is confusing to me because I was under the impression, based on previous communications and messaging, that primary care reform has already been happening, and in fact that there was an initial attempt to make team-based care, and then there was a huge rearrangement of that team-based care. I think it was last year, it was rolled out. And I was under the impression, based on communications, that was primary care reform being rolled out. And now I'm hearing that we're just starting the process of thinking about it. So can you explain what was the basis of last year's primary care reform that seemed to cause quite major disruptions in practitioners' work schedules and access to care and affected patients? If that wasn't primary care reform, or was it, what was it based on if we're only starting now to do the necessary engagement and planning and analysis that would result in proper planning for primary care reform? Thank you, Madam Chair.
Thank you. Minister?
Thank you, Madam Chair. So how I would like to answer this is, there has been pieces of it, like as Nina has mentioned, and she can kind of elaborate to, there has been pieces of it that has been rolling out through, because, you know, like we said, this started as a direction 10 years ago. There are pilots, like we talked about in Fort Good Hope with the virtual care pilot, and so now we're gonna take that and we're going to, and so Yellowknife, I think what happened was, is it was faster than maybe some of the, how do you call it, the work that goes into change management, because of the move into the Kliwagonti building and to the primary care. And so I can turn it over to Nina to bring it back to where we are with primary care and how that took place into it, and if there's more details that you need afterwards, you know, we can have Claudia or Jennifer within the Yellowknife region as why and how that piece happened. So if I may, I can turn it over to Nina.
Thank you,
Yes,
Madam-
please proceed, Nina.
Thank you, Madam Chair. Thank you, Minister. One of the things I want to confirm is that primary healthcare reform started and was launched 10 years ago, but demonstration projects took place since 2018 and a few assemblies ago. And so integrated care teams were in place in Yellowknife, and last year operational change were required. And so those were made based on the move to the new building. Something that is important to remind ourselves is around the topic of issues. One thing that we're looking at is when there are issues, oftentimes our culture and the health system is we're very quick to find solutions, and we are quick to listen to one voice to come up with that solution. And so primary healthcare reform is really based on sitting down together as a team, a diverse team that also has Indigenous people at the table to fully understand the problem and come up with a solution that can meet the needs of those who will have the highest needs. If we're able as a system to meet those with the highest needs, we will automatically create a system that benefits the dominant white population in the NWT. For Yellowknife in particular, we are scaling for primary healthcare reform in the sense that over the last year, we've worked closely with the authority to set up a governance model, like Dr. Kraft have shared, where we have a diverse team who is there to look at the issues that are taking place in primary care and identifying solutions to resolve those. One of the key issues, of course, was brought forward by physicians. And we know that physicians are critical leaders of the system, but we also know that not one profession should bear the full burden of care. And so really, as part of primary healthcare reform, is to really look at how do we set up a team that can fully support the needs of clients in the NWT. Thank you.
MLA Morgan, do you have a follow-up question?
Yeah, thank you, Madam Chair. And I should have said too in my opening, what I'm hearing or understanding is that the reform that was done, even though we refer to it as it was done in Yellowknife, that it had big impacts on care being delivered in many of the small communities and communities outside Yellowknife, in that the doctors who may reside in Yellowknife may have had relationships in some of these communities and been visiting regularly, or had sort of regular assignments in small communities, and even that was disrupted by some of this reform. And so I think, and I should say too, that I'm not just hearing from doctors, I'm hearing from other kinds of health care practitioners within the system, which absolutely have a key role to play in the team-based care. And I think there was frustration all around amongst lots of different players, that not that people are against any change, but it felt like the disruption was not sort of well thought through in terms of the ramifications and implications on things like care in small communities that hadn't necessarily been considered. And so the change was made, and then it's like, well, the sense was we'll just see what happens. And that it was, we're just going to implement this and ask for feedback later. But I think many of the practitioners within the system felt that they would have had really great input to give up front to prevent some of the unnecessary disruptions and things from happening, that things could have been arranged differently. So I think that was the frustration, not that there was any change whatsoever, but that there's lots of ripple effects that they could see on the ground that was not being considered in the implementation of the plan. My second question, though, has to do with your slide around the Made in North curriculum, and that you're designing this new curriculum to help communities and teams work in this new way and sort of get on board the principles of primary care reform and a community-driven approach. My question is, who will this curriculum be delivered to? It says it's designed to help communities and teams, but can you explain what is the problem that this is designed to solve, in the sense of what kinds of people are in what kinds of positions are currently not educated or not on board with the principles or the ideas, or that need these workbooks and presentations and case studies? And can you just sort of explain how this would be rolled out? I'm not clear about who this is being delivered to and what's the rationale for what that's going to accomplish. Thank you, Madam Chair.
Thank you, MLA Morgan. Minister Semmler?
Thank you, Madam Chair. Madam Chair, I guess what I want to clarify too is primary care reform is the overarching how we are going to provide care to residents in the Northwest Territories, and guide that work is the framework that is being developed and these little projects. So what happens in the operations at NTHSSA and when they make those changes is in alignment with some of the goals and objectives of primary care reform. And so primary care reform, like the department, like Nina's team at the health department, in the Department of Health, not in NTHSA, didn't decide to and give direction to, that's an operational thing. So I just want to make sure that those two things are separate and clear, because the work of the primary care reform, which goes down to what you're talking about, is actually going to, I mean, even myself as an Indigenous person, sometimes I start to delve into the stuff that when we look at a system, I was trained in our system, the way that we provide healthcare and have for many years. And so when I go and look at, I guess we were more of a, different, it's a different system, and then we wonder why many of my own family don't have comfort on accessing, or they phone me when I was a nurse to say, how come they did this and did that, because they don't trust the system. And so what I want to say is that even my own bias, being trained in a system, I had that bias. So, and I'll say that now, because I've identified that. And that's what I'll turn to Nina, is to provide these types of training for our teams so that we can go, oh, yeah, that is true. So,
Thank you, Minister.
if I can.
Yes, please proceed. We have 45 minutes here. Please shorten it.
Yes.
Thank you.
Thank you, Madam Chair, and thank you, Minister. It answers a simple question. We will have a framework, and while we develop this framework, the work still continues. How are we going to implement primary healthcare reform? And the modules are made for that. They are made for the CEO to assemble a team and to figure out what are the needs of the population, how will they design their health system together, what are the issues that need to be addressed, and how will we go about doing that.
Thank you. Thank you. Now I'll go to Mr. McNeely and to Ms. Yakalai after. So, Mr. McNeely?
Thank you, Madam Chair. I really sort of enjoy discussing the problems we're having, and we have a movement or a framework called healthcare reform. But in my view, the main problem,
Mr. McNeil, can you answer, ask a question, please?
okay, let's cut to the chase and be blunt and frank here. The recruitment plan, okay, what is the recruitment plan? How are we promoting it? We're designing it. I've got a graduate that's graduating from high school in Cove Lake. I've got another graduate from Good Hope that is graduating here in Yellowknife in nursing. What are we doing to promote trades? I've submitted a proposal to government. I haven't heard word back yet. I want to promote trades by soliciting this voice, demand for trades at the high school. That's, to me, that's the main problem. You can have this beautiful building. If you got nobody in it, how are you going to provide health care? Thank you.
Thank you, Mr. McNeely. Minister Semmler, to answer the question, please. Thank you.
Yeah, well, within the, recruitment for health professionals into the system, we have a human resource plan that we've extended, and we have a new plan, I think, being released in 2025. I'm not going to go into the details of that recruitment plan, but as to, when we talk about the things that you're talking about, MLA McNeely, is how are we getting into the schools? How are we engaging these students? How are we bringing them in? I think that's a collaboration of the whole of government, and NTHSSA does use those tools. So we have the, bring a child to work day, and we do that in health systems. We have those who have graduated and that are planning on going on to post-secondary, or, we have the summer student GNWT wide. So if there are, a health center in your region, then, we've encouraged everybody to hire a summer student that are, especially those that are going into those health fields, so that they have the time to experience. Internally, there are jobs that people start in on the front line that are, once they graduate, and then they kind of see what goes on in the health. And you've had some people who go, I want to be a nurse and I want to work in that area because I worked around that area, so that it provides that ingraining. As for, going into more detail, I'm not sure how much more I can add to this right now here. Into what we're doing. I think if there's anything further, I'll leave that to Mr. McNeely.
Mr. McNeely, do you have a follow-up question?
Thank you, Madam Chair. It's not really a question, it's just a follow-up. This to me is a real serious issue, but we're always given limitations. You only got 2 minutes to speak. This is a 2-decade problem, and I'm only allowed 2 minutes. So I like the doctor's comments. They want to invest into recruitment. I admire that. Thank you.
Dr. Croft? Okay, now Minister.
Yeah, no, and I hear that, and I think that's a collaboration that I've been talking with, we have the Aurora College. We are all constantly, we've got federal dollars to continue on with providing the LPN program. That has gone straight to ensuring that we are, growing our own LPNs. We've got the personal support worker program. We've had the registered nursing program for many years. And, they're launching now the social work program. So that's health and social services. It's not just nursing within our system. And so there's many, many tools that we are working collaboratively with the Aurora College. Thank you, Madam Chair.
Thank you. Now I will go to Ms. Yakalaya.
Thank you, Madam Chair, and thank you for your presentation. It's really good. I'm listening to everything and thinking about how, I guess my question was similar to member from the SATU on recruitment. The reform will only work as long as you have resources such as practitioners, nurses, physicians, and stuff. And I'm speaking for small communities. So, and given that we have such a, with what we're going through in our communities presently with the drug issue, the addictions that's happening, how is that going to be dealt with? And have you looked at, when you're talking about reforming and including the Indigenous perspective in a healthcare team, I guess a lot of things you look at that, there are some barriers to that, and that's something that you'll have to work through in the communities. Some things, I guess for me, I just have to say some things that we have in our culture that we keep to our culture. So that's the way things work. So, and then looking at liability for decisions of healthcare outcomes. You know, how are you going to deal with that if somebody gets really sick using traditional medicine? You know, and things like that. So that's something to be aware of. And yeah, just looking at the homegrown issues. We have people in our communities that are not going anywhere. They want to stay home. You know, recruiting those ones, looking at those ones, getting the idea into their head that, you know, being a nurse or a practitioner or a teacher, whatever you want to be, is something that you should really look towards doing, because you'll get a good lifestyle out of it and you don't even have to leave home. So providing some kind of incentive to them, for them to really look at practicing healthcare, you know, so it's more of a comment that I wanted to make. But looking at, yeah, it's going to be some challenges going through this, and I guess looking at what we're facing today, it's a challenge, and I wanted, like, for me, timelines. When is this going to be implemented? And like Mr. Moore said, what is it going to cost us? What is it going to cost the territory? And when is it going to be? What's the time frame, and what's it going to cost? Thank you.
Thank you, Minister.
Yeah, so we I think Nina has answered to the timelines and the costing that's going to take place. So over this next year, that will be the work that's being done. So as is in the presentation, and I understand where you're coming from. Yes, we do need more of our own people going off to school and doing the programs so that we can hire them. I think we are hiring every prospective nurse, you know, that LPN, PCA that's coming out of school, where we've opened up new long-term cares. We have future of more long-term cares. We need more personal support workers, you know, and I think that's the thing is that we do need more people in the communities, and that's where, you know, primary care reform is like the overarching, but it's also fitting in all the little pieces that we're doing, and like Dan has said, like, we're following the journey. So what is needed in those small communities, and that small community model is going to feed into this. And so, like you were saying, is that there are more things that local people can do in the community that are going to help health promotion and do the work that those people that we say don't, you know, I've been to communities, and you've raised it in the House, like with the health promotion stuff. Like, people need to be out there doing this and giving this information out so people know how to care for themselves. And when they're afraid to even access and walk through the health center door, or they're not going to school, and then so they're not, you know, they're not seeing and they're not going anywhere, then there's an issue. So this is more than just health. This is communities and everything in general to move forward in a better way, to provide services and accessible services in the Northwest Territories. And it's not going to happen overnight, because we didn't get here overnight. This is years and years of being told us how to run healthcare. We drew down this healthcare system in '88, and yes, we did not have traditional healing when we drew it down from the feds, and we do not provide traditional healing. But what we do is we provide funding to Indigenous governments if they want to do that. But Nina's team is actually working with pilots and doing some of that work. And how do we, and trying to find that way to incorporate that into our system. We're not saying that if you have a certain disease, then you can choose these models, but this is something that, you know, as a personal choice, if you're not accessing health, will this help you, enable you to actually feel safer in our system, to access other systems, like other healthcare services in our system, if we can provide, you know, a better, more comfortable and open door. Thank you, Madam Chair.
Thank you. Ms. Yakalai, do you have a follow-up question?
Yeah, thank you. Well, it's not a question, but more of a comment. I guess I can say that the healthcare reform will only work if you have a system that, like right now, currently, the communities are in, a lot of communities are in distress dealing with addictions. So the resource part of it, the creating the resource part of it is not gonna happen until we work with the communities to deal with the addictions and the issues that are, the mental health issues that are facing the community right now with the drug crisis in the north. You know, I don't see how this is gonna work unless we deal and work with these issues. So that is more of a comment from me right now. Thank you.
Minister, do you want to reply?
Thank you, Madam Chair, and I'll be short. We've started this work in the Beaufort Delta. And it is taking a client-centered focus on mental health and addictions and what the needs are. And I think they've recently just finished the work in the reviewing on and consulting with the SAW2 communities on reforming their mental health and addiction services in that region. So every region, my understanding, will hopefully have that done, and that way we providing centered, the care that's needed based on what the client's need is. And so within that mental health and addictions, we have this same old model, cookie cutter model across the Northwest Territories, and we're seeing that working with Indigenous governments, they're all collaborated, they're in one office, and so you can choose to go to the GNWT worker or the Inuvialuit, or there's different. So there is a different way of providing care, and we're open to that, and that's primary care because it's centered care around the patient. Thank you.
Thank you. MLA Reid?
Thank you, Madam Chair, and thank you for the presentation. I appreciate it. I have a question around one of the forces that will support system transformation that you spoke about in your presentation, specifically modern digital infrastructure. Mr. Florazone spoke about it earlier. There was some commentary around e-health records especially. But my question is there an overarching project management on health's information system infrastructure requirements writ large? And if so, are there priorities and a timeline for that work? And how does it overlap with the work of Mr. Florazone, this primary care reform, and the health system sustainability? I see it as an overarching piece that affects all three of those initiatives and really crucial to all three. So thank you, Madam Chair.
Minister?
Thank you, Madam Chair. That is, that lead, I think, is in the department, but with collaboration with the health authorities, and I can pass it over to the Deputy Minister to give you a brief little fill in the gap.
Deputy Minister?
Thank you, Minister, and thank you, Madam Chair. If I understand the question correctly, we are leading this work in the department, as Minister said, in collaboration with the health authorities. It is anchored in the EHR work or the EMR work, whereby there are about 70 programs within that basket of work. And so AI, virtual care, e-consults, all of those things are part of those components that would be considered within our EHR. So when I mentioned earlier to MLA Morris around that we are taking this year to work with Alberta, as well as to look within our own system around what are those changes we need to make, because we do recognize our current system is lacking even in the areas that you mentioned and that I noted as well, and Mr. Florazone had noted. We know that we need to modernize our way to provide electronic services, for example, and charting services to our clients. So I'm not sure if that's helped answer that question, but if I've missed the mark, please clarify or let me know.
MLA Reid?
Thank you, Madam Chair. And yeah, I guess I'll drill down a little bit more. I guess are all of the requirements on track to be assessed for those 70-ish programs? I'm interested in how we are assessing them, complementary projects that are overlapping, that I mean, it's a very, I understand it's a very complex problem to start unteasing all of the digital requirements for many, many pieces. But I guess I'm seeking a status update on the project management of it all, what sort of timelines we're looking at to have the majority of operability available. And obviously, the Alberta piece is a huge part of that, but not the only part, because obviously for equity and health services, we want to make sure that, you know, if someone's coming in from Wati, that they need specific things in their own health center, or if they're coming to Stanton, and all of that interoperability to be able to be helped when they're at their home community, be helped at Stanton if they need medical travel. The rest of it, obviously, e-records are important, but there's much more to it than just charting. Thank you, Madam Chair.
Okay, thank you. Minister?
Yeah, thank you, Madam Chair. If I can have Perry Heath, he's online, to answer that.
Yes, please go ahead.
Hi, Madam Chair. Can you hear me okay?
Yes, we do.
Thank you, Madam Chair. So getting to the answer, so the business capability model, as the member talked about, is being discussed currently, and the business is actually completed. It's involved the interaction between 400 different practitioners and people within our system to help develop that business capability model. That work is complete. We're in the process of finalizing the final stages on the request for proposal for the procurement of that, the EHR, the system. But in parallel, as the deputy spoke, we're also investigating opportunities with Alberta. We've had a formal dialogue and back and forth with them about whatever we end up procuring, whatever way that system works, that will be done in conjunction and interoperable. It is our anticipation that within this fiscal year, we'll be out to procurement or have the model finalized in procurement in process. Thank you, Madam Chair.
Thank you. MLA Reid? Okay. I do have a question too as well. You know, I know that you guys talked about racism. We know that racism is not a new thing. It's nothing new, especially against the Indigenous people. It's been with us since colonization, so, you know, racism. But I just want to say, I know that in Bichico we had a hospital. It closed in 1974. And we had another hospital built after that one closed. It was a cottage hospital. It closed in mid-'80s. Now we have a health center. And Mr. Florazone said, yes, Stanton is a busy place. And we see an ambulance going from Bichico to Yellowknife every day, you know, and Joanne was a nurse over there, so she is aware of that. And you said here in your report that, you know, redesigning the primary health care started 10 years ago to improve the Indigenous health outcome. And the Stats Canada a while ago, I'm not too sure if it's changed, but the lifespan for Indigenous people was 65 years. I'm not sure if that changed. I hope it changed. That was due to the lifestyle that we are living and the care that we receive. And in most health health center in the small communities, we have x-rays. But we don't have access to, we need more resources that we know, you know, that we need ultrasound, we need to do more blood works, we need to screen for cancer, etc. And lately, our people have been getting diagnosed at a late stage, especially for cancer. And that's really sad, you know, like maybe if we had a good healthcare system, I mean, especially in small communities, maybe all these could have been avoided. So, and I know that right now we need to improve the healthcare system, especially in small communities with resources, to have our health center operate effectively and efficiently. So, so instead of reforming, redesigning, why not build on what we have? Why not fix what we have now and build on it? Why the department is not taking that approach? Because, I mean, just, it's, you know, if we have more of those, I think a lot of things could have been avoidable. So why not build on what we have now? Why the department is not taking that approach? Thank you.
Thank you for the question, Madam Chair. And what I want to say is that I think when we look at primary care reform and the goals and the objectives of primary care reform, what we've seen in our small communities is a form of the primary care reform, and what you're saying is, why don't we better it? That's what we're doing. I've directed the PA to go out and map the journeys of from the smallest communities, like our health cabins, as to how they move along in the system, so we know exactly where their needs are, and exactly to say what you said. What can we put in that community that is going to limit their need to have to travel out of that community? So can we do point of care testing? Can we do other systems in that community that they will get that quality of care, but they don't have to continuously travel for it? And what primary care and the anti-racism and, and in that umbrella is, you said it yourself, our people are coming to this health center too late, because many times before maybe they went there and they didn't feel safe and they didn't feel like they were heard, so they're not going to go there until they really need to. And now they really need to because they're in pain, and now they have 3rd stage or 4th stage cancer because they've not wanted to deal with those small little, complaints, because sometimes they've been overlooked, or they felt that they were overlooked, or, the health center hasn't been open because it's on emergency services. There's many different reasons, and so we are broadening and we are expanding, and that's that model of care. So there's more work going on in the small communities to do that. And I think in the end goal is that Northwest Territories residents as a whole, whether you're Indigenous, you're non-Indigenous, you're new to this country and you're coming here, that you're all safe and you all have access to health care. And primary care reform and the goals and objectives of that's the outcome. And so in the capital, we're going to have less pressure on our regional hospital, on our territorial hospital, because people are getting better access in the communities and in their regional center. So this is, as I said it before, it's not going to work overnight. This is something that I think a lot of us in healthcare, and I've been in healthcare and I work alongside people who've worked in the system their entire careers, and they're like, we're finally getting to this. This is some of the work, because we're always trying to stay above water, but we finally have all these things aligned. We have a public administrator in place. We have direction from this government to, access to health care is a priority, and that means the whole of the territory. And we have a health sustainability unit to make sure that it's sustainable, so that we know where we're spending our money and that we can continue to sustain an equitable healthcare system for all our residents, no matter where you come from. So thank you, Madam Chair.
Thank you. For the whole of NWT, you know that half of the population is Indigenous, and most of them live in the small communities, and that's where that disadvantage is. So that's who I'm here for, because this is what you said in your opening remarks, that, to redesign primary health care in all of the NWT. And then at the bottom, you said 10 years ago, it was, this committee, it was given to this committee to improve the Indigenous health outcomes and explore. So that's why I'm saying, why not build on what we have in small communities? Because you said it already in here. You didn't say, you said all of the NWT, but all of the NWT is mostly Indigenous people. So, and here, I'm just going by what you have here, improve the Indigenous health outcome. So, with that, I think my colleagues, they've already said it, the timelines. And they asked when, is it going to take another 10 years to improve the Indigenous health outcome? Or is there, or is it just as we go along? So what is the first priority for this, for the client center? It's for the client, it's for the patient health outcome. That's what you said, so thank you.
Thank you, Madam Chair. And as we move forward, and as we're doing the pilots, and as within the NTHSSA, with the work that the public administrator and the leadership within NTHSSA is doing, is that as they look at what's going on in the health center, like the model of care I said. We're taking that model and we're re-envisioning it and what it needs. And then we can say, okay, in this region, this is what it needs to provide care. And it's going to take, you know, it may take more resources to do that, or we may find efficiencies within there, because there are things that, you know, we have vacancies for long periods of time that funding, you know, is there, but it's not being used because you're never gonna hire that kind of a personnel in there. And like you said it yourself, and there was a hospital at one point in different parts of the territory, and federal government at the time, that was under their jurisdiction, and due to, you know, however they decided that those facilities were not meeting whatever requirements was to continue it as a hospital. In the Northwest Territories, we have 2 designated hospitals, and the rest are either health centers or health cabins. So Stanton is one of them, Inuvik is the other. So the rest of the health centers in the Northwest Territories are either health centers or health cabins, and we are looking at them as how. And like you said, we're like in the statements, yes, we're doing this primary care reform because it's a new framework, and we're trying to establish it so that way everybody's on the same page. So that way, when we're in a region, and we know that your region is different than my region, and so we need to be able to be flexible in that, and so that what your needs are may gonna be different than what Nunavut needs are. So we have to ensure that those changes take place, and if there's current positions there that are, you know, maybe we need to change what they do, because the need is in that region. So that's the work that we're doing as well. But that, you know, as for this whole, it's centered around the client and the needs of the client. So, thank you, Madam Chair.
Thank you. We still have 15 minutes. If a member have we still have time for second set of questions or second round. And if there's no more, okay, MLA Morris.
Thank you. The next question that I had, and it's, you know, focusing again on the primary care teams, something that I've noticed has declined, and I'm just going to speak to my own experience of the healthcare system over the past couple of years. I've noticed that continuity of care has really crumbled in my personal healthcare. And I'm not sure, well, I have an idea of what all the various factors are, but I mean, one thing that stands out to me is that, you know, every single time I book an appointment, I'm seeing a new doctor from the south. I don't have a family doctor currently. I think there's lots of folks who are in that position. And so you're kind of re-explaining to them what all the problems are. And I find what often happens is I'll come out of an appointment and they're like, you know, you really should get, you know, follow up on this in a few months. And you get kind of an advice for timeline. And anyways, without going into the whole story, I know that continuity of care is really important for healthcare, and it's something that has really been facing a lot of challenges in our system lately. I'm just wondering, how can we better grasp at that problem, knowing that the problem of needing to rely on locum doctors isn't going away tomorrow? I think obviously, again, our goal is recruit from the north as much as possible, recruit physicians that want to stay here. I heard Ms. Kraft kind of speaking to that and appreciated those comments, but how can we ensure continuity of care in a system that does require locums so often? And yeah, thank you.
Okay, Minister?
Yeah, thank you, MLA Morse. And, you know, and I know I've said this before, and it's not a negative thing against, because I think that's the thing is that when you have had only access either in, I mean, even in my own community of Inuvik, we have some great doctors who have been there for many years, and so there does feel like there's a continuity of care when you have this physician-based model of care. And in the capital, this has been the model, and we have had long-term doctors for as long as the model has been in Yellowknife, and as long as there has been primary care or health clinics. But the change into primary care reform is, you know, I think is not new to, or the primary care model is not new to small communities, and as MLA, as the chair has said it many times, is many times doctors and nurses going into the community, and if you've been in for the last 20 years, you will see a different person every time. And so this is not something new to the rest of the territory, but it is new to the capital, where it is now a pressing issue for many residents of the capital. But I mean, this is why I think, and I'll turn it over to Dr. Kraft, is to say that the hope is that, you know, these teams and these models, that you will have a team that will be, you'll know your team. If you have a chronic disease, you will be able to know your team and who you need to see. If you're somebody who's relatively healthy, then you may not need to access a team. You may just need, you know, those one-offs here and there and go through the walk-in clinic or something like that. Those are the different options out there, whereas you're not always needing to see, because once you see them, then you can probably have your record and those types of things. So it's not necessarily, if you have a team, every single time you need to be seen, you need to see your physician. So I'll turn it over to Dr. Kraft.
Yeah, Dr. Kraft.
Thank you, Madam Chair. Thank you, Minister. Thanks for the question. I think I'll sort of, there's a lot to unpack in it. It's not a simple answer. In regional healthcare, we have, as the minister, you know, mentioned, we don't have physicians or nurse practitioners in most cases living in most of those communities. So the continuity often is with the rest of the, I'm going to put air quotes on the team, right? The other people that are part of that primary care experience. So you can have great continuity, and even other models have done this. So NUCA as an example, right? Your continuity sometimes is with the program assistant, the CHIN, right? Sometimes it's a nurse practitioner. Sometimes the continuity can be in the consulting person, right? So in communities, we have we're taking the inventory right now of what's working really well in places outside of Yellowknife within the territory. So for example, in the Sahtu, there are a number of what we call long-term recurrent locums. So it's a small pool of people that come back frequently. They provide remote care, virtual care, when they're not in the community supporting the nurses. And it's not perfect, but it does address some of the reality of how do we allocate resources in the most continuous way that we can. And there are other examples of how we're trying to do that. And I think our public administrator already alluded to that there'll be some announcements around locum incentives today. So this will also include some specific targeted incentives around recurrent locums, long-term recurrent locums. In Yellowknife, you're right, there has been, I think for many people, an experience of less continuity with their practitioners. Particularly when they've been accustomed to seeing the physician. Because in Yellowknife, the past model has been that, you know, everything sort of funneled through the physicians, and then as the team sort of expanded, then things got redistributed. And we're really trying to invite, you know, the model that the communities are using, where there are other people, CHINs in communities. In some cases, it's nurses, nurse practitioners, nurse case managers, public health nurses, who then, when the patient's problem warrants it, bring in the physician. So it's sort of turning that inside out. So that does mean that it's, for some people, they're going to see less of, for example, a physician on a regular basis, because the healthcare needs that they have don't need that. That's not who's going to best serve them. But hopefully it also means that some people that haven't had access to the continuity that they needed will be able to, right? So, you know, elders living in long-term care probably need a little bit more nurse practitioner or physician time than a healthy 4-year-old on a wellness check, right? Whose care could absolutely be done really well by public health nurse, maybe better than what I would do in the clinic. We also have some competitive advantage. Like we recruit, on the physician side, we have, our competitive advantage for recruitment is that we offer some of the best parental benefits in the country. So absolutely, we have people that are entitled to parental leave, right? So that creates gaps that we have to fill. This is the same for, you know, for any healthcare provider. Shorten it up. Okay. Okay. And we also we recruit people that we call them full service, certainly on the physician side. And so many of our doctors, wherever they are in the territory, are working parts of their work in the hospital, delivering oncology or babies or other roles. And so that does erode the amount of time that any one given practitioner is in the clinic. So that is another changing demographic pattern in our practice here in the territory that we have to be aware of.
Thank you. Now I have Ms. Yakalaya.
Thank you, Madam Chair. My question is, what does healthcare reform, what will it look like for small remote communities that have just a health cabin? There's a number of health cabins. I have a health cabin, well, I could say maybe, I don't even know, no, I know Kakisa. For instance, for Kakisa, what does that look like? For an initial health checkup, because they only have a health cabin, they don't have access to a nurse or a physician in the community, there's just a health cabin. What does it look like for them, this healthcare reform? Thank you.
Thank you. Minister?
Yes, thank you. And I think that just with time, I would love to give it over to Dan and to talk about the work that he's doing, but I'm sure he can do that when he's in front of committee. But again, with the work that his work plan is doing, but he is actually with his team at NTHSSA, they're doing that work. They're taking the work, and I think this is kind of where I was, even myself, is that as a minister, I'm used to the region that I came from. I worked in it, and I know health cabins and what they access and how they access, but it's a different when I've been as minister in the different regions. And so when you look at like the Decho, which has, I think, 4 health cabins in their region that they serve and 2 health centers, then, or 3, I think, 3 health centers, and yeah, the numbers are, they have a lot more health cabins than most regions, than the other regions, then it looks a lot like it's piece, like every region, because we were 6 health authorities, every region did service their region the way that they decided, right? And now we are all one, and over the last 10 years, you know, I think that's the thing is we've tried to cookie cutter a lot of the things, but we know that there's a lot of issues, and we've talked about medical travel, we've talked about increases of, you know, people, you know, are sicker more, and so that is the work that NTHSSA is taking on right now, and they are doing it, and they are starting in the Decho, and I'll say that publicly because that is where they have the most health cabins, and I want to know how do people in Kakisa know when and how to access health care when they don't have a health center in their community, period, right? So we need to know that, and they need to know that, and the public needs to know that, and our healthcare staff need to know that. So that's the work that the NTHSSA is taking on right now. Thank you, Madam Chair.
Ms. Yakalaya, do you have a follow-up question?
Yeah, I do. So given knowing all that, why is it that we need, I mean, you gave all the reasons why we need to have this healthcare reform. Why can't, like Ms. Armstrong talked about, just build on what we have already, add to it, create what you need to do to it, get it going, so we don't have to sit around and wait for another year, and it's going to cost us X amount of dollars, and then we're going to have to put all of these. So just build on what we have right now, create something from there, and then move forward. This has been going on for 10 years. It's frustrating to sit here and listen to this and say, you know what, yeah, we're gonna have another process happening. This process may take another 5 years. We don't know. You know, hopefully it doesn't. So I agree that with what Ms. Armstrong said, that we should just build on what we already have, because it's not the perfect system. It's not working, otherwise we wouldn't be sitting here talking about it. So something's not working, let's add to it, move on, keep moving, because Right now, we're dealing with crisis after crisis in our communities, and we're dealing with the shortages of physicians and all of that stuff. So I don't know if we don't have any people in our communities, what's the sense of having healthcare reform? Thank you.
Yeah. Thank you, Minister.
Thank you, Madam Chair. And like I said before, we are not recreating the communities. We are building on the needs of what the community residents have and what the needs are now. There is a gap, and that is what we're in the analysis that's going on. That's got nothing to do with primary care reform. I mean, it's pieces of it. It's the overarching is, in the health centers, we have been having that model of care where, you know, to a T, there's some things that we do different, but it is that we are building on that. You're not gonna see, you're gonna still see chins in the community, but you may see other people in the community. You may see LPNs, you may see, you know, what's the other, paramedics in the community. You may see different people working as government employees in the communities now where you didn't see it in the model before. And so that is, it's got, you know, and so we're not saying that we're changing. I think the biggest change is felt is in the capital, and it's gonna be in the region centers, because those are, like we said at the beginning, the region and the capital, primary care is the clinic pieces, right? When you're not the hospitals, but the clinic pieces, and in the health centers, the clinic pieces are our health centers. And so that's the biggest change, is that concept of this team approach, where we've always had a team approach. I worked as a public health nurse. I sat as a team, you know, for the community, and with our home support workers. I sat at rounds to make sure our patients that were in the hospital, that's always been there. So we're expanding on it, and we're actually formalizing it, that it's a way that we're going to do healthcare in the Northwest Territories.
Thank you. Our time is up. So I just want to say thank you to Minister and to her team for coming, for joining us. So now this concludes the public briefing on reforming the primary health care. Thank you.